The webinar is being live streamed now. Good morning, everyone. I'm Dr. Hita Patel, and along with me, Dr. Alopi and the Dr. Harsha ma'am from the IEP Digital Media team, and we will be hosts for the today's webinar, which is specifically meant for the conference. And for today, we'll be having the symposium, and we have uh, it is being organized by IAPWC Gujarat State. The Indian Association of Physiotherapists is oldest and largest association representing representing the physiotherapist in India since 1955. The IAP Digital Media team is a consist of a group of physios who handle Zoom platform, Facebook, Instagram, Twitter, LinkedIn, and YouTube. Follow the IAP profiles on the social media to receive the notifications for our events such as webinars, workshops, CMEs, conferences, health camps, blood donation drive, and to know about the recent updates on physiotherapy. Subscribe to IAP YouTube channel for the notifications of our live webinar in the playlist section of this channel. Webinars are segregated into various folders on the topics like orthopedics, neurology, sports and fitness, pediatrics, cardiopulmonary, women's health, research, cancer rehab, and many more for the easy access. The social media link will be shared in the chat shortly. Further today, of our anchor is Dr. Komal Patel, ma'am, who is an district coordinator at Anand district from Gujarat State IAP Women's Cell, and Madam is also a assistant professor at BN Patel College of Physiotherapy. We welcome you, ma'am. The floor is of yours.
Thank you so much, ma'am. So, starting with today, good morning, respected judges, faculty members, and dear colleagues. It gives me immense pleasure to welcome you all for today's symposium presentation session, along with our virtual IAPWC case series, Gujarat State, which adds great academic value to this platform. Today marks an important step in our academic journey, where ideas begin to take shape into meaningful research and clinical insights. Through both symposium presentations and case discussion, we aim to bridge the gap between theory and real world practice. We are honored to have our esteemed panelists with us, whose valuable insights and guidance will surely help refine these research ideas and clinical reasoning skills further. Without taking much time, let us begin this session with enthusiasm and a spirit of learning. Thank you, and let's get started. So now I would like to welcome Dr. Grishma Shah, madam, who is a moderator for today's symposium presentation. She is MPT in neuromuscular disorders. Dr. Grishma Shah is a neurophysiotherapist and assistant professor at Asuk and Rita Patel Institute of Physiotherapy, Charuset, an academic gold medalist from SSG Hospital, Vadodara. She specializes in neuromuscular disorders and neurorehabilitation. Dr. Shah serves as the IAPWC sub-coordinator for Kheda district and is also a global burden of disease collaborator, reflecting her engagement in professional and global health initiatives. She has delivered academic sessions, served as a judge at professional events, and contributed to the profession by translating the World Physiotherapy Day toolkit into Gujarati. Her academic work includes scientific presentations at national and international conferences, a peer-reviewed publications, and she is also a recipient of the SSIP grant supporting innovation and research. So, floor is yours now, ma'am. Grishma.
Thank you, Komal ma'am. Thank you so much for the lovely introduction. So here we are starting the first session of the day, a symposium presentation. So good morning, everyone. Let me just begin with a simple situation that I think every physiotherapist here would have faced. A patient comes to you, looks at you, and comes up with a straight question that, doctor, what do you think that will work best for me? In that very moment, what makes your decision? Do you rely on the previous experiences that worked for your similar patient, or do you go and search your guidelines, references, and textbooks to guide you, or do you take advice from both? So this very thought-provoking dilemma forms the foundation of today's symposium topic, that is clinical decision making in physiotherapy, science, experience, or both. Clinical decision making is at heart of physiotherapy practice, influencing how we assess, plan, and deliver patient care. Through the symposium, we aim to explore how physiotherapists integrate evidence-based practice and clinical expertise to make effective and patient-centered decisions. To explore this theme systematically, today's symposium has been divided into 4 key elements, each addressing an important dimension of clinical decision making. The first segment will introduce the concept of clinical decision making and evidence-based practice. The second part will highlight the importance of evidence-based practice in guiding clinical decisions. The third will focus on role of clinical decision expertise in physiotherapy practice. And the fourth and the last segment would be how can we combine the clinical expertise and evidence-based practice in making decisions. So, to begin with our discussion, it is important to understand the basic concept of clinical decision making and the role of evidence-based practice in physiotherapy. I would now like to invite Dr. Pallavi Biryani ma'am. She is an assistant professor at KD Institute of Physiotherapy, Gujarat University. She is a PhD scholar in community health and rehabilitation. She has an over 5 years of academic experience with additional clinical practice. She is a research contributor with publications in Scopus and Web of Science Index journals. She is an expert speaker and judge at national physiotherapy conferences, and she is actively involved in research, community health initiatives, and physiotherapy education. So we now invite Dr. Pallavi ma'am to enlighten us on the topic of clinical decision making and evidence-based practice, which lays the foundation for the discussion that follows after. So we welcome you, ma'am.
A very good morning to one and all present here. Thank you very much, Dr. Grishma ma'am, for such a profound introduction. First of all, I would like to thank the organizing committee of IAP Women's Cell Gujarat State to give me the opportunity for being a speaker in the symposium. And I would also like to thank our state head, Dr. Jaspreet ma'am, Dr. Alpa madam, Dr. Advita ma'am, and Dr. Ruchi ma'am and Dr. Sanjeev Jha sir. I would like to share my screen and start with the presentation. Is my screen visible, Grishma ma'am?
Yes, ma'am, it is visible. You can slide show it.
Okay.
Done. Visible.
As Grishma ma'am has briefly introduced the topic, clinical decision making, experience, science, or both, I would also like to start with the basic part of this symposium. Whenever this terminology comes, it always is a dilemma, right? As Grishma ma'am said, that we are always confused when this term comes. Whenever a patient comes, we are supposed to take some specific type of decision related to their condition on the basis of many factors. Let me first tell what basically clinical decision making says with an example. Consider a patient is coming to OPD with a complaint of shoulder pain. The first thing which we do is we take a subjective assessment that includes the demographic details, history taking. The second thing which every physiotherapist does is taking an objective assessment. The third thing done after doing a thorough assessment, after doing a subjective and objective assessment, is we do a critical thinking and we come to a specific clinical decision, coming to the parts of differential diagnosis. And at the end, we decide the treatment protocol. Now, here, when we come to the third stage, that is critical thinking, it gets divided into two portions, and there are many factors that will be affecting it. First, when you think about critical thinking, as I have shown in the image, there is a rabbit and there is a tortoise. We all are very well aware of the story of the running race between both of them, and always the rabbit runs fast and the tortoise goes in a slow motion. But does that means that critical thinking is fast or slow? So, yes, we usually think in two ways, whether you correlate this in a physiotherapy field or even when you correlate this in any of the fields, we have two thinking strategies. One is thinking fast, and second is thinking slow. So when a patient is coming with a shoulder pain at the clinic and patient complains that I have difficulty in overhead activities and combing hair. So when a person is doing a quick assessment and only on the basis of these findings, they just quickly assess the range of motion and they do not thoroughly assess the patient, and it is diagnosed as frozen shoulder. Now, when we are thinking this same condition as slow, when you go into the part of thinking slow, same patient, same complaint, difficulty in overhead activities and combing her hair, taken a quick assessment. Now, when you want to think critically, there should be a trigger, any part, any point wherein in your assessment that should trigger you that okay, now I need to take this condition in my mind and I need to divert my mind from thinking fast to thinking slow. So the trigger, for example, in this condition we can consider that we have taken range of motion and the finding which we get is a painful range of motion from 60 degree to 120 degree. We do the capsular restriction checking and we get to know that there is no capsular restriction, the capsular pattern is tested, and eventually we diagnose it as painful arc syndrome. So this is how thinking slow works, but not in all the scenarios we can go for thinking fast or thinking slow. Now I have just generalized these two terminologies, but then we also have a scientific terminology for this. But does that mean that slow and steady will always win the race? As I explained in the previous slides, that thinking fast might take the patient in a condition where the patient is misdiagnosed. So, does that mean that slow and steady is always true and thinking fast is wrong? No, that is not the scenario, because there are many confounding factors which we need to take into the picture. Thinking fast is termed as fast and frugal heuristics. If I elaborate the term heuristics, it is basically our gut decisions or our intuitions. Now, from where we are getting those gut decisions or intuitions, they are coming on the basis of our past experiences and whatever the experience we have with our patients in the clinical setup, whatever knowledge we have gained in the clinical field, in our academic field, and eventually a person combines the past experiences, the intuitions, the knowledge, the evidence, and then they are able to give a fast immediate decision. Now, where are we going to use this? Where will you use the heuristics and thinking fast approach? It will be used in situations where we want a rapid decision, where the information is only limited. Consider that you are walking on a road and somebody has met with an accident and there is an emergency situation. You need to give basic ACLS or basics cardiac support to that person. So you are going to take immediate decision. You are going to check the airway. You are going to check the breathing and circulation, and you will immediately start with the CPR. So in all those scenarios, we are going to use the approach of thinking fast, or the scenarios where we need to take the decision on the basis of our intuition. But when you are taking the decisions on the basis of intuition or gut values, it is only possible when there is a substantial amount of experience you have gained in those situations. We are not commonly using this approach in physiotherapy. The question comes that why we do not use this. I gave a very basic example of an emergency situation, but when I think of a case wherein I am sitting in a clinic and sitting in a OPD and a patient is coming to me with a complaint, and I cannot just quickly say that okay, you have a shoulder pain and you have a complaint of combing your hairs, so it is a frozen shoulder and let us start with the protocol. No, because thinking fast mostly is used in biomedical approaches, and in physiotherapy when we talk about approach being used, that is biopsychosocial. So we are going to combine the physical health, we are going to combine the mental health, and we are also going to combine the social aspects, and this is where the community reintegration comes into picture. So we always cannot use the thinking fast approach in physiotherapy. So does that means that thinking fast in physiotherapy is wrong? Not at all. It is not wrong. What should we use then? I have given both the ideas, thinking fast, thinking slow. Made you explain what is thinking slow, and till now it goes that okay, that we should always think slow. But the scenario does not always works in that way. Whenever a patient is coming to OPD with a clinical presentation, the first thing we see that if a person is complaining and the symptoms and signs are familiar to us, then those familiar signs and symptoms leads to intuitive system processing. Now this intuitive system processing, again as I mentioned, that will be gained on the level of knowledge, on the level of experience. So this is the system one that gets activated if you have a familiar signs and symptoms, and once that this system is activated, here comes the heuristics into picture, and the intuitive system processing heuristics comes into picture. Along with applying the knowledge and experience, the diagnosis is made. Now what will happen if there is a second scenario wherein there are unfamiliar signs and symptoms? So here, when there are unfamiliar signs and symptoms, we need to take into picture a analytical system. Here the analytical system comes into the processing. Now if the analytical system comes here, you have some trigger warning that okay, during the assessment a patient, you saw that 60° to 120° is painful, so that is a trigger. You assess capsular pattern and again there is no restriction, again that is a trigger. So you are differentially diagnosing all the shoulder pain conditions, and you critically think, you generate a hypothesis, and then you come to a specific diagnosis that okay, the symptoms were unfamiliar. Now what will happen if a person continuously comes into that picture, that a patient clinical presentation is done, unfamiliar signs and symptoms are coming, and analytical system works. Now this happening over 3 4 years, 5 years, 6 years, continuously assessing shoulder pain patients for many years, and also going through the evidences and gaining skills. So repetitive practice will take the person into the intuitive system one processing. So in a way, this whole chart describes that both the systems, whether it is system 1 and system 2, are interrelated, and clinical based decision needs to be taken into account by thinking both the ways, by pattern thinking fast or thinking slow. Now, there are factors that will be influencing this, intrinsic factors as well as extrinsic factors. I will briefly introduce these factors, that how the clinical decision will be taken into account. I have mentioned that thinking fast is heuristics. You are going to use the intuitions, but then everybody has different personal experiences. So coming to intrinsic factors, we divide them into two, that is patient factors and human factors. If I talk about patient factors, the disease the patient is suffering from, what is the family support, what is the cultural belief related to that disease, what is the networking options which they have, or is there any comorbidities already present. There might be a patient who might have same case scenario in their home, and they might have considered that okay, इनको भी ऐसा होता था, so that is why this is the only same thing which is going to happen to me as well, right? Second, coming to human factors, uncertainty. You are not sure about the diagnosis or about the decision. Clinical experience, again very important, as I have mentioned almost in all the slides this word, that is experience. If you have experience in that specific condition, you are treating frozen shoulder cases or shoulder pathology cases since many years, and then you develop a grip, you develop a skill for thinking fast and intuitive thinking, and you come to a diagnosis. Third is professional risk. Coming to any such conditions wherein the risk factors are involved, so these will be the human factors. System factors and team factors, that these are the modifiable factors, the external factors which can be modified. Intrinsic factors will be the one which we will not be able to modify. So hospital structure, how the hospital is working, what is the structure, what is the workload. Consider there is a OPD of 100 and the OPD is working only into the timeline of 9 to 12. So managing, and when we talk about the manpower is also less. So what usually the clinician will do, they might uh, think fast in the process of completing the OPD and handling all the patients. So here the diagnosis might go again wrong. But again, this practice can be practiced, this skill can be developed with time. Protocol and CDSs, wherein the defined protocols are set that this is the system, and if a person is coming with a shoulder pain, then he needs to assist in this manner only, or these are the only few exercises that needs to be given. So that protocol system again cannot be changed. Team factors, how the team is working, what is the culture of the team, is there any hierarchy that needs to be followed, or the dynamics of the team, or what is the team support that is being given, or that is how the whole team is working. Team culture, whether the in the hierarchy, for example, the in the hierarchy, the professional who is at one level up, he or she has the tendency to think fast in all the scenarios, and they are not able to identify the triggers. So here it can again lead to the wrong clinical decision. Again, these all factors are influenced by the bias, by the cognitive thinking of an individual. So according to the situation, it needs to be taken into account whether the person needs to think slow or the fast. These are the references from where I have taken the content of the presentation, and thank you very much. Keep learning, and at the end I would like to say that no, the slow and steady will not always win the race, and even the fast and furious will always also not win the race. Both of them have to win the race together, keeping the simultaneous coordination. Thank you.
Uh, thank you, Dr. Pallavi ma'am, for such an elaborative understanding on the clinical decision making and evidence-based practice, guiding us through the think fast, think slow, and how heuristics are developed, and how is one responsible for taking decision on the base of heuristics. So while understanding the concept is important, but while knowing why this evidence-based practice is important in our clinical decision making is the next step we would like to look on our journey to this symposium. So for that, I would like to invite Dr. Priya Singh ma'am. Dr. Priya ma'am is an assistant professor at LG Institute of Physiotherapy. She is MPT in Rehabilitation and Community Health. She is a PhD scholar from Gujarat University. She has a vast experience of 8+ years in academic and clinical experience. Her research focuses on menopausal health, women's health, osteoarthritis, and community rehabilitation. She is an editor of multiple physiotherapy textbooks published by JP Brothers Medical Publishers. She is also recipient of multiple best paper and poster presentation awards at national conferences. So we invite you, ma'am, to elaborate on the topic of explanation about importance of EVP in CDM. We look forward to your insights, ma'am.
Thank you, Grishma ma'am, for such a wonderful introduction. I would like to thank Indian Association of Physiotherapists Women's Cell for giving me this opportunity to be a part of this symposium. And I'm thankful grateful to my wonderful team, all my panelists and moderator, Grishma ma'am, for being so supportive. Uh, Now let's start with the presentation. Grishma ma'am, is the presentation visible?
Yes, ma'am. It is visible.
Okay, ma'am. Okay, so as wonderfully explained by Pallavi ma'am, uh, we have learned how important evidence-based practice or how important clinical expertise is when we are looking at clinical decision making, and how different types of biases may come into picture when we are relying on clinical expertise alone. So that is where evidence-based practice comes into picture. So when we talk about evidence-based practice, what is EBP? When we are looking at clinical decisions that are based solely on experience, it may lead to inconsistencies in our decisions because these decisions may lack the scientific evidence that is required. Whereas, on the other hand, if we are making decisions that are based only on research, they may lack individual relevance. We not be able to modify or conform our treatment plans according to the need of the patient. So, if we look at both these types of decisions, one that is based only on expertise and two that is based only on the available evidence. These two types of decisions alone may not be able to satisfy the needs or the requirements of our patient. Hence, in order to give a more wholesome uh, management for our patient, we need to bridge these two different decision making processes. So, we need to bridge experience with research. And that is what evidence based practice does. It bridges the gap between science and real world practice. So, what is EVP? EVP is clinical decision making that is based on the best available evidence. So, we look at the research, we look at the literature, and we try to find out what is the best available evidence pertaining to the condition at hand. Second, we look at the context of care. In what way are we going to plan caring for the patient? What are the unique circumstances of this particular situation? What are the resources that are available with me? And this can include what is the client's current situation, what is their current condition, what culture they belong to, what resources I have in my clinic in order to plan an intervention protocol for my patient or assess my patient. The third is what is the client's preference. Sometimes the clients have their own preference. So we may have a different management protocol in mind, but the client may not prefer that particular management protocol. So we also need to keep in mind what is the client's preference. Because if we are not keeping that in mind, the client is not going to be happy and the client is not going to get better. And lastly, we also need to look at our professional judgment, the clinician's expertise, experience, and critical thinking to interpret and apply information to that particular unique situation. So it isn't that we always need to look at the best available evidence at hand, but we also need to have our own expertise. What have we seen in the past? How have the patients gotten better with the interventions that we have given to them? How the patients have reacted to the interventions that we have given to them? So that builds up our expertise as a clinician. And all these together, all these factors together, best available evidence, context of care, client preference, and professional judgment. All these different factors, when they are taken care of while making the clinical decisions, they will give the best possible outcomes. Now, moving on to what are the 5 steps of EBP. So, when I talk about evidence based practice is a step by step process. It has to be a scientific approach which merges with our clinical approach. So the first step of EVP is ask. So what do we ask here? So like Pallavi ma'am already explained very beautifully that when the patient is coming to you are performing an initial assessment of the patient, and then based on the assessment, you are planning your management. Now, when I say you need to ask questions, that is the first step of EBP. So, what are we asking here? So, when you are performing assessment of the patient, you need to ask which approach for assessment will be best for this patient. But say if I am trying to assess pain, so I have multiple options in order to assess pain. I may just ask the patient what is the severity of pain, or I may have some particular scales like the visual analog scale or the numerical pain rating scale or the percentage scale or the facial rating scale. Now, since I have so many multiple options, how do I know which particular scale should be used for this particular patient? So that is the question I need to ask. Which scale for pain should be used for my patient? So that is asking the question. Second is acquire. Here we are talking about acquiring the knowledge, acquiring about the best evidence that is present for this particular question. So when I say which particular pain scale I should be using, so I need to go back to my evidence and I need to look for studies that have compared the different scales that can be used for pain. And I need to gather all these different research articles. I need to scrutinize them. The third step is appraise. Now, appraising is appraising the evidence that we have found. Like I said, that we need to go back and we need to look for literature that is comparing these different scales of pain. So when I gather all this evidence, when I gather all these different research articles, I need to critically analyze and I need to critically appraise each of these articles, because not all articles would be of the same quality. Not all articles would be of the best quality. I need to scrutinize and appraise articles which are of best quality. And based on this, I need to decide that which pain rating scale would be best for my patient. The fourth step is application. You need to apply. Now, whatever I have known, whatever knowledge I have received based on all this gathering of evidence and scrutiny of evidence, I need to apply. So, say for example, if I have found that the visual analog scale is the most reliable scale for this particular patient, say any condition, if say we are talking about osteoarthritis. So, for osteoarthritis of knee, the visual analog scale is the best pain rating scale. So that is my conclusion based on all the clinical evidence. So I need to apply visual analog scale in my patient. So that is application of the appraised evidence to practice. And then I need to audit. Another step, the fifth step is auditing. You cannot just apply and leave. You have to audit. You have to evaluate the performance of whatever tool you have used or whatever intervention you have given. You have to evaluate whether the tool used by you has actually given benefits or not, how it has performed pertaining to the subject. So when I say VAS, there might be patients who would be able to understand VAS, and there would be another set of patients who may not be able to understand VAS that nicely. So if I apply VAS on my patient and I realize, okay, yes, my patient is able to understand VAS, then it is fine, it is okay. But what if my patient is not able to understand VAS? What if I find that the patient's understanding of VAS is different and the patient has not put down the correct findings? So here I need to evaluate the performance of the test and then I need to reanalyze. So if my patient does not understand VAS, I need to maybe go to the second best pain rating scale, which say maybe NPRS. So since VAS cannot be applied on my patient, I need to use NPRS. So these are the 5 steps of evidence-based practice: ask, acquire, appraise, apply, and audit. This is a small example. So, say a patient is coming to you with acute low back pain. Now, whenever a patient with acute low back pain comes, you know that you cannot give any deep heating modalities, and even heating modalities would be contraindicated in the acute inflammatory phase. So you have two options at hand. You can either give TENS or you can give IFT. How do you know which particular modality to be used in this particular patient? So what do? You go back and you put down the question. You ask which modality should be used, IFT or TENS, for a patient with acute low back pain. You move on to the next step. You acquire the evidence. You acquire the best available evidence pertaining to this question that you have put forth. Next, you try to appraise that evidence. Fourth step, now, when you are gathering this evidence, I have shown one example of a systematic review with a meta-analysis, which says that both TENS and IFT, they have similar effects on pain outcome when we are dealing with acute and chronic pain. Now, based on this particular study, I should be able to realize that whatever modality I'm using, TENS or IFT, I'll be getting good results. I'll be getting similar results. So that is appraising the evidence and then coming to a conclusion. The next step is applying. So TENS or IFT, I can apply any of these modalities. Now, next, what I need to think of, I also need to take care of what is available at hand, what resources I have, what is the client's preference, what is going to be more economical for me and economical for them. And based on all this, I decide whether I want to apply TENS or IFT. So that is application. And then comes the last step. Once you have applied TENS or IFT, you also need to audit. You need to see whether the application of TENS or IFT has actually reduced the pain in that particular patient or not. If, say, you had applied TENS and the patient gets better, it's okay. But if you apply TENS and the patient does not get better, then maybe you need to think about applying IFT. Okay, so that is the 5 different steps of EBP. Now, moving on to the importance of EBP in clinical decision making. Why is EBP important when we are looking at clinical decision making? It improves the quality of healthcare that we are giving, because whatever healthcare we are giving, there is a scientific basis to it. And also, we are taking into consideration all the other factors like client preference, the context of care that we need to give, and the clinical expertise. Secondly, it reduces the cost of healthcare. Since whatever decisions you are making are based on all these 4 different factors, you know that your modality, whatever you have chosen, your decision is going to work best for the patient. And that is why there will be reduction in the frequency of reinvestigation or reassessment or re-intervention. Whatever intervention you have chosen, whatever assessment tool you have chosen, that is going to work best for the subject. It increases safety of the patient as well as practitioner. Since whatever management plan you have formed, whatever assessment plan you have formed, there is some scientific basis to it. There is some clinical basis to it. Your patient is going to get the best care, and hence that is going to increase their safety. Also, for the practitioner, since the patient is going to get better, the practitioner also remains safe. We right now are living in an era where legal lawsuits are very common, and patients also can legally sue the therapist. When your decisions are based on both scientific evidence that is available and clinical expertise, since you have some strong scientific evidence in order to support whatever decision you have made, you can try to protect yourself against any possible lawsuits. It improves patient outcomes. So since you're giving the best management plan, you're giving the best assessment plan, you're giving the best of care that is possible to your patient, it improves the patient's outcomes. It keeps your practice updated because since you are using the best available evidence, you keep on looking at whatever new research is coming up, whatever new literature is coming up, and you try to keep yourself updated. So you are no longer using the traditional methods of treatment. You are no longer using the outdated methods of treatment or assessment, but you are keeping yourself updated and you're moving with times and you're trying to update your practice as well. So this is what keeps your practice updated. It promotes consistency and standardization. Since whatever management plan or assessment plan you have made is based on scientific evidence, you are going to be very consistent with your patients. So, any type of patient that you're getting, you're going to have a consistent approach to it, an algorithmic approach to it, and you're going to standardize your plan of care. So that gives you an edge over other people who may just look at the availability of resources. Okay, so I do not have a TENS machine available and I do not want to buy TENS. And that is why I give hot pack or I give ice pack. So, no, that is not done. You cannot do that to a patient. Whatever modalities you are using, whatever treatment approach you are using, it has to stay updated. It has to be consistent. You cannot just make decision based on the availability of resources or just your clinical expertise alone. So it promotes consistency and standardization as well. It strengthens professional credibility. Since you will be giving the best results to all of your patients, that is going to strengthen your professional credibility. That is going to increase the number of patients that you will be getting because the patient is going to have trust and faith in you. And also it enhances clinical accuracy because whatever plan you have created, it is going to be based on some scientific literature. So that is going to make your clinical judgment, your clinical decisions more accurate.
Hello, ma'am. I'm sorry to interrupt, but we can
Yes, ma'am.
pace it up as we are
Yeah.
getting a sort of.
Yes, sure, ma'am. Sure. Next is role of EVP in CDM. So evidence-based practice can be applied to all the different domains like assessment or diagnosis or intervention or outcome evaluation. You can use validated tools for assessment. You can use evidence-based criteria for diagnosis, like for example, using the ACR criteria for diagnosis of OA. Your intervention plans, your treatment plans can be based on EVP, and you can use standardized measures for outcome evaluation also. What are the different problems when you're applying EVP? So the amount of evidence that you may get, that may become unmanageable, and you may not be able to decide which research to go to, which research to believe. So that may be enormous. The volume of evidence may be enormous, and you may get confused sometimes. Statistically significant benefits may be marginal when you're applying them to the clinical practice. So you may see that there are statistically significant benefits, but that does not translate into your clinical practice. And this is where terms like minimal clinically important difference come into existence. So you're not just looking at the statistically significant benefits, but you are also looking at MCID. So what is the clinical benefit that the study has proven? Inflexible rules and technology driven prompts may produce care that is management driven rather than patient centered. So, there are certain centers which may just give you an algorithm that you need to follow this, and they may not allow flexibility. So, you may not get your own decision making. So, they have made decisions, they have made approaches, and you need to just follow them. So there might be a problem in applying EBP because you may not be able to you may not be allowed to make any decisions of your own. And evidence-based guidelines often map poorly to complex multimorbidity. When you're talking about one particular condition, using evidence is easier. But when you're talking about different comorbidities existing together, it becomes difficult to get evidence for so many comorbidities. Limitations of EVP. Not all clinical scenarios are going to have strong evidence. Sometimes you may get patients from certain rare conditions which you may not be able to find good quality, strong evidence for. The research may not reflect individual patient complexity. So, when you talk about research, you get one forthright case, a simple case. But in clinical scenario, it is not such. There are different complexities that may be present with your patient. The patient may not have financial resources. The patient may not be able to come daily. The patient may have certain other economical and social motivators or barriers which you need to look into. So that increases patient complexity. And lastly, time constraints. When you are in clinical practice, you have so many different patients to look at. You may not have the time to dedicate to EBP. The key message here is that EBP is not cookbook medicine, but it is individualized, informed decision making. It does not replace clinical expertise, but it enhances and validates it. It transforms decisions from opinion based, that is just clinical expertise based, to outcome driven. So you also need to look for outcomes and you're not just looking at your own opinions alone. Thank you. In case you have any questions, we will be taking questions at the end of the symposium. Thank you.
Thank you, Dr. Priya ma'am. Thank you for such an elaborative session on EBP. What are the 5 ways of EBP and what are the problems that can be encountered because of EBP? So it is very important that how a research evidence makes a physiotherapist's clinical decision more informed, more safe, and more effective. So we all know, but however, that research evidence only doesn't shape our clinical decision. So to move on to our next topic, the physiotherapists highly rely on their clinical judgment skills, their experience, and their expertise. So moving on to our next topic, that is explanation about importance of clinical expertise in CDM. I would like to invite Dr. Shipra Shah ma'am. She is an assistant professor at Ashokan Nitaparan Institute of Physiotherapy. She specializes in musculoskeletal and sports rehabilitation. She is a consultant physiotherapist and certified diabetes educator. She actively engages herself in academics, clinical practice, and research. She focuses, her research area is focused more on integrating physiotherapy with lifestyle management in diabetes care. She advocates for holistic rehabilitation, incorporating yoga, nutrition, and preventive health. So we invite Dr. Shipra ma'am to enlighten us on how a clinical expertise is going to shape the clinical decision making. Welcome you, ma'am.
Thank you so much, Grishma ma'am. Let me just share my PPT first. I hope it is visible. Is it?
It is visible, ma'am.
Okay. Thank you once again, Grishma ma'am, for the wonderful introduction. First of all, good morning, one and all present here. And I would like to say sincerely thanks to the IAPWC Gujarat state team and for giving me this valuable opportunity to be part of this symposium. And it is a privilege to be here as to share my thoughts on this topic. And when we talk about this topic, it is like it is very centered to our profession. But when we don't discuss with enough depth, because we think that we know everything about this thing, because we are practicing from many years and all. So, title for today's symposium itself is very interesting. That clinical decision making in physiotherapy, science, experience, or both. So that question sounds simple, but in reality, it is a very important and practical question. Okay, so because in physiotherapy, every day you see many patients, you require to take many decisions. We decide what to assess, what to prioritize for the patient, what treatment to begin with, what to avoid, and how much to progress, when to modify, when to stop. So many questions are there. So the clinical decision making is not a separate academic concept. It is the heart of clinical practice. This is my idea that is the heart of clinical practice. So today, when I'm focusing about specifically on the importance of clinical expertise in CDM, in this process, we hear a lot about the evidence-based practice. Just now, Priya Madam also explained the importance of the evidence-based practice, their limitations, their few 4As also she explained. And we apply this in research, we apply for the protocols, we apply for the guidelines, and all of that is necessary. But at the same time, if we ignore the value of clinical expertise, then our decision making are not complete. It's basically incomplete. So by this, let's start the presentation. Here, what you see, it is a bridge of rock. Okay, so it taught us, like, we follow the evidence, we have to follow the evidence, we have to follow the guidelines and protocols, just now I said. But in real clinical situation, things are not that simple. We often am I audible, Vishwa ma'am?
Yes, ma'am, you are audible.
Sorry, because it shows that my internet connection is unstable, so that I asked.
No, ma'am, you are audible and visible.
Thank you. So we've taught to follow these evidences, protocols, and guidelines. But often in clinical practice, what happens? The clinical judgment is incomplete because we don't have full contact about the patients. They follow the textbook patterns without questioning. Research findings cannot always be directly applied here. We cannot ask patients just how it is looking like a patient. It is just similar to the textbook, what you have learned from the textbook. So for example, a study may say that exercise works, but it does not consider for every patient, because they have patient fear. We have other different compliances. We have different lifestyles from the patients, multiple conditions they suffer. So there is going to be a gap that what evidence tells us and what real patient present, and that gap is filled by the clinical expertise. In clinical expertise, we do not develop, that clinical expertise does not develop overnight. It is actually a gradual process. You cannot say that if you just passed out from the fourth year and you are so experienced. Students are practicing this also, that they take patients on the higher level, that they have to treat those patients because they show themselves that they are so expertise in that condition they are treating. But initially, we gain experience by seeing patients. But experience alone is not enough here. We must also do some reflection, asking ourselves, why did this treatment work? Why did it fail? So this comes here, the evidence. What evidence Priya Madam also and Pallavi Madam also have given introduction for that. So that comes from the evidence. You read about that. We update about that knowledge through our research. You refer that things. But next is judgment. When you come see patient, you refer your notes, you refer your evidences, and then you come for the judgment. So we start identifying the patterns and important clinical clues. So finally, for these, all of these combine to become an expertise, where the decision becomes more clear, more faster, and more accurate and more confident. That comes as a clinical expertise here. When we talk about the architecture of the mastery, the question is here, how a physiotherapist grows professionally. You strictly follow the rules, what you have learned from your seniors, what you have learned from your teachers, what you have seen doing in your OPD timings in your hospitals. Like step by protocol, you follow that. But at the advanced beginner stage, we start recognizing that pattern, still need a guidance. So for that guidance, we come to the competent level. We plan treatments and we handle it complexly. So for this competent level, at this competent level, we are aware that, okay, this patient needs this much of intensity, this patient needs this mode of exercise, this many reps these needs. But at that after that again, the next level comes, that is the proficient level. So we begin to see the bigger clinical picture here. And finally, at the expert level, the decision becomes intuitive. We just know what is right based on our experience. And this everything involves your knowledge, your tactic knowledge, which is things you cannot fully explain, but understand that other pattern recognitions. You identify what clinical trend right now is going on, and your professional judgment. Okay, your decision making power, your certainty of making the decisions, that shows your professional judgment. So here you fulfill the architecture of your mastery, that you become a clinical expertise in clinical decision making. Here, just like it gives a numerical evidence of why expertise matters, because 47% of clinical decisions happens in the situations where evidence is unclear, so many times it's insufficient also. So when you are an expert, 3 times you'll be faster and more accurate in diagnosis compared to the beginners. Definitely, because you have an experience. But about 60% of patient outcomes also depends on the therapist expertise, not just on the protocol. And about 85% of patients prefer the experienced clinicians when choosing care. So what expertise is not just a theoretical, it is also a measurable impact on how accurate you are, how speed you have to find out the diagnosis, which outcome you are using to find out the condition, and how much the patient trusts you for that. Okay. In the clinical practice also, patients are not, as I said before, even though Pallavi madam also say, patients are not just as simple as textbook, because they present with psychological factors like fear, anxiety. There have other issues also. There are multiple coexisting comorbidities like diabetes, obesity, thyroid, and other issues, and different movement behavior also. They learn from their beginning, from their childhood to for these patterns. Okay, for example, when we talk about the low back pain, around 90% cases are classified as non-specific, and there is no clear structure. Because so, like, how do you treat such patients? So we cannot just rely on a diagnosis, we cannot just rely on a protocol, what is mentioned for in textbooks, or you have research papers also, but you see patients. So we need that clinical expertise to understand that what is the movement pattern of that patient, why this patient, what are the patient's belief that he's having this pain and all. Okay, and what are the functional limitations, because it will also again change from individual to individual. So these all factors, these all are the real clinical reasonings happens to diagnose the condition. Here you shows your clinical practice. I think, ma'am, my slides are changing. Yes. When we talk about again the expertise, the clinical expertise required at very stage of the patient's management, right? So in the beginning, you heard Pallavi madam was explaining about the assessments. So subjective assessment also important. We read between the lines, not just what patients saying. We also observe what patients mean to say, and what they mean to explain here. And from the objective assessment, we select relevant test, not all the test. Expertise here select the relevant test after seeing the patient's condition. And in assessment and in diagnosis, in assessment and diagnosis, we cannot find logically just putting it on the level like we are finding it on the clinical diagnosis. It is a critical thing. We are we are coming to the assessment part. In this planning, we individualize, give a treatment, not just to follow the generic protocol that, for example, patient come with a frozen shoulder. So every frozen shoulder patient will be having the same scenario, same complaints also. So later on, when we start with the protocol, we have to reevaluate the patient. So we decide, is the treatment is working? Do we need to modify it? So in this last step, it requires the highest level of expertise because it involves the decision making under uncertainty. Here, the cases is like 22-year-old runner present with the anterior knee pain. Diagnosis is a PFPS, patellofemoral pain syndrome. And this protocol-based approach, the standard assessment has to done. We have to strengthen the quadricep as it is prescribed, and patient education we have to give. And again, we'll review after 4 weeks. This approach is based on a strong evidence, but it is not generic. It treats the condition, not the individual. It assumes that PFPS patients all are the same. But in the other side, on the other side, when we, I'm sorry. I'm sorry. On the other side, when we have here the evidence with the you can look into the table now. We have evidence is that instead of stopping the diagnosis, the clinical expertise should go little more deeper. Here we identify what is the training load error as the main issue, detect hip weakness and pelvic drop during the movement. We redefine the diagnosis to biomechanical dysfunction. Now here the treatment changes. So you will add the hip strengthening instead of only the quad strengthening. Okay, you will adjust the load management. You will teach if the person is not wearing the proper shoes. You will again teach them the gait retraining. And at 4 weeks, when the pain reduces significantly, your treatment will modify it again further for that. So this is the personalized care here. This is not a generic care. And this is the difference between the treating as a diagnosis and treating as the patient. On the complementary strength, now this clearly shows that either the evidence nor the expertise alone is sufficient. Evidence provides the objectivity and generalizability, but here the individual context is lacking. But expertise provide the personalizations and the adaptability, but it can have the bias. So best approach is here to combine both. That this is the true evidence based practice, not choosing not over the other one. So just combine. You should have the evidence also, and you should have the expertise also, and combine that approach and treat the patient for that. In this, how we actually apply evidence, this also explained by Priya madam, that 4 A's. I'm not going much deeper in that you have to ask, acquire, appraise, and apply. Define the clinical question, search for the evidence, and check the quality. And lastly, apply with the integration with the patient context. So, for example, here in ankle sprain, evidence suggests that peace and love protocol is for ankle sprain patients. Expertise adds specific tests, and they add also sport-based rehabilitations. But patient wants early to be on the field. So the final decision here is to be modified, not rigidly, but following the protocol, but it has to be patient-centered. When we talk about the true EBP synthesis, the evidence-based practice is often misunderstood. It is not only research, it is not only experience. It is integration of best available evidence, clinical expertise, patient values. So these all three, evidence, expertise, and patient values, all these three must work together. If anyone is missing, decision-making becomes incomplete. On the last, conclude this session, that evidence, if I say evidence is a map, it's like a map, and it shows the path. But at the clinical expertise is like a compass, which actually gives the direction. If we only use evidence, we may get lost in real situations. And if we use only experience, we may lack scientific grounding. So the best clinicians practice here is to combine both. So clinical decision making is not a choice between the science and experience. It is an integration of both approaches together. Thank you, madam. Thank you.
Thank you, Shipra ma'am, for shedding light on how a clinical expertise allows physiotherapists to integrate the evidences in a real-world patient scenarios. So this brings us to our natural question that how do we effectively integrate clinical expertise along with the evidence available on the internet. So to bridge this question, we have with us, sorry, is my screen visible? Sorry
No,
for the
ma'am.
glitch. So for this, we would like to invite Dr. Vaibhavi Ved ma'am to help us guide on the session. Just a minute. Uh, uh, I'm extremely sorry for the delay, but it was the screen sharing was paused somehow. Bridging on to our next topic on how should we combine or how should we effectively incorporate the EBP and clinical practice to bring out the best possible patient outcomes. We would like to invite our next speaker, Dr. Vaibhavi Ved ma'am. She is a founder and chief consultant physiotherapist at Arham Multi-Speciality Physiotherapy Center, Rajkot. She has done her master's in orthopedic and sports science, certified and antenatal, postnatal, and women's wellness therapist. Uh, she is in physiotherapy faculty at Tattva Naturopathy College, Rajkot. She was a former assistant professor at RK University. She is currently serving as a Rajkot district coordinator at IAPWC. She has also been awardee of Rising Star at the IAP conferences, and she is an active contributor to sports physiotherapy, women's health awareness, research publication, and community health initiatives. We welcome you, ma'am.
Thank you so much, Grishma ma'am, for your warm welcome. Good morning, everyone. A hearty congratulations to all the speakers before me. Uh, I have been given a topic of bridging the gap of clinical expertise and evidence-based practice. So far, what I heard from the respected speakers, I think both the speakers have very well concluded that the integration of clinical expertise and as well as evidence-based practice can only lead you to a good practice. But I would like to give a little gist to this topic in a way that everybody could put into a regular practice very nicely. Bridging the gap, bridging the gap between evidence-based practice and clinical expertise is one of the most significant challenge for a physiotherapist. So I consider it to be an art of taking, like it's like something what a research paper is saying, and now you want to apply it to a human who is sitting in front of you. So yes, very true. EBP will give you a map, but it's only the clinical expertise or the intuition which would help you to navigate that direction and to have a best outcome for your patient. Next. So most of the time evidence based practice is misunderstood, like it is considered to be a, 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 a protocol which is to be followed, but rather here is it is a structure called three-legged stool, wherein there is a combination of individual clinical expertise, at the same time best available clinical evidence, that too from a very good research background, maybe a systemic reviews or RCTs or some good peer-reviewed journals you are looking for. And at the same time, patients' values and expectations. Why? Because at the end of everything, it should be a shared decision for the patient's well-being. So only then optimal outcome can be achieved. And all three legs of this tool, they are very important. If all three are balanced and taken into consideration, it would give you an improved quality care for the patient as well as the satisfaction for your patient. Now, individualization, again, clinical expertise plays here a role where uh, from research you get something which is for a more generalized way, a protocol which could be followed. But when you have a patient in front of you, your patient's goal from your side as well as patient's own expectations would be different. So in that case, it is your individual expertise and experience which would help you to develop a more tailor-made protocol for your patient. So in a way, it is a dynamic process where all three processes are interconnected. I think each of these legs should be strong enough so that it can provide. I know all of you understand that any of this leg, if broken or if it is less, it's a weaker one, it would not give a proper stable base. So for a reliable decision making, all three components should be properly uh, understood, and all three components should be properly practiced by a clinician to have a better outcome. Next. So I would share through strategies how we can bridge this gap. Basically, it is our bench to bedside mastery because it requires a shift of understanding that EBP is not a static set of rules which you have to follow, but we have to make it a dynamic one by adding our clinical expertise and making the clinical decisions. And thus, what all strategies as a clinician you can follow. And being into an academic and a clinical field, this is a very close topic to me. I would always like to bridge a pure student to a clinician, because a student to clinician journey, that gap is, it would always be the best way you can deliver to your patient. Next. So clinical reasoning frameworks first and foremost. Now, clinical expertise isn't just having a feeling, it is a structural thinking. Like you can use some base example here is of an ICF model where you try to treat the patient on the basis of that model. So, if you are treating a torn meniscus patient, it is not the pathology as a physiotherapist what we treat. We treat the motion, the biomechanics, the function. And so, I would like that, and every clinician should look it at as treating inability to squat, to pick up a grind trail or pick up something which is there from the ground. So, as a clinical therapist, we should look on the activity limitation, the functional recovery of the patient rather than treating the pathology. Next. Next is the knowledge translation cycle. Research often takes years to reach to clinic. It is very sure. As we already discussed about the limitations a therapist would have, a clinician would have to enter into the research or go through the things. But there should be timely certain things practiced by the clinicians to have a better outcome in their practice. One of the most valuable thing which could be added in the daily practice is journal clubs. We used to have this when we used to study, but this journal club help you to discuss about the new papers, discuss among your peers, and you have some debate regarding the practical application certain times. And when a group of expertise come together, Like a very good example is this conference itself, wherein we have experts from around I must say, at the national level even, who are sharing their expertise, and we are having a very good knowledge to understand, to come across new practices in the clinician, and to bridge our academic knowledge with the clinical practice. We can even use certain clinical prediction rules. Basically, CPRs are the ones which tell you that particular protocol would how help, or would be how much be helpful to your patient to gain the recovery. So, what kind of patient response you will receive once you give a specific type of intervention. So, CPRs also can be used by the clinical therapist to have a better clinical practice. Next. The third thing is reflective practice. Now, this is again very much important. As a clinician, if you are an expert clinician, you would always try to learn from every patient. It is rightly said, your every patient and individual patient, every condition is different. So, reflection in your action as well as reflection on your action is very important. When it is reflection in your action, it's like adjusting your, you are doing a manual therapy for your patient, for n number of patients you do, but you should be very clear, and you should change your manual pressures according to the patient's guarding. Like no two patients muscle response would be same. So once you are treating two patients, maybe same condition and same treatment protocol, but you have to change according to the individual reaction to your treatment. So could be a slower pace for one, a faster pace for other one. So this is what have you reflect in your own action. At the same time, reflection on your action is also very important. How? Like you have to review. It's like what I say is, in a clinical practice, assessment is every day, or rather even every session. When you start your treatment plan, and you must have a assessment, and at the end of your plan you must have an reassessment, that how far your treatment protocol has helped the patient, whether you need to change or whether you need to continue the same, progress it, and how you should go. It's not like today you are assessing a patient and you are assessing after 15 days, then you definitely are a very slow thinker, I must say, what Alvi ma'am had discussed. You have to be a fast thinker, specifically in this era of AI and Gemini, where people have everything on their tips. And if you want to have a good clinical practice, it is very much necessary that you assess your patient, evaluate your patient every day, and you might have to design your protocol, change your protocols according to their recovery, perhaps every day, to have a early recovery, early return to their functions. Next. Now, some common barriers, and how do we overcome them? Like we want to bridge this too. We want to have a good practice, but how can we overcome? So, next, the first barrier which we talk about is time constraint. Okay, so what can be done as a clinician for this? So you can have some point of care like summaries, like Pedro, Cochrane. They give you summaries instead of reading the whole article. So in that case, you can save your time. You can easily access. And I must say, a good clinician must always be a good researcher too. It is very important for you to always have certain time where you spare for your research work, for your, maybe you are doing some one or the other readings, so that you stay updated, and that is how you can give your best to your patient. Now, the research doesn't fit my patient. This is also one common barrier which we all of us see, that recognize the research provides, naturally the researchers would provide a very generalized treatment, but then when you are an expert, experienced therapist, you will know how to modify the dosage, how to deliver, to have a fit and a individual, how to fit it to an individual who is different from the other. At the same time, certain times, one more barrier is cognitive bias. Like we try to always prove what we know, and we try to find out that. So that is what is called cognitive bias. We have to be very much aware of the confirmation bias. Like we only keep on looking for the evidence that support what we already do rather than finding out something new, something better which could help your patient. So always be careful for this type of biases which you develop in your own self. So rightly said that your eye can see only what your mind knows, and for that I would suggest that more of your practice reading researches. If you know about things more, you can definitely see whether it is a diagnostic level or a therapeutic level. In both the ways, you will be able to have a broader vision. Next, now as a clinician, talking about when I said this to you that your eyes can see only what your mind knows, I would like to share few experiences about my clinical practices. Like, for example, let us consider a patient of cervical radiculopathy. Now, you have a patient of cervical radiculopathy. A patient will come to you with the symptoms of pain. There would be spasm. The patient would say that I have a tingling numbness up till uh, three fingers of my hand, and it is
Ma'am,
treat the with cervical traction. But in that case, first, as a clinical therapist, you must assess your patient. Certain times, your radicular pain is out of a chronic myalgia. Now, when a patient is having a chronic myalgia and you are introducing traction to such type of patient on an initial stage, it would be rather a devastating or a harmful effect to the patient rather than helping them. So, this is where your clinical expertise would help you. You will have that instinct to decide when this particular evidence based treatment can be started, or whether it is the right time to give everything, or how do you tailor make, or how do you specify that protocol for your patient. Certain times you are given certain repetitions for your exercises, and you have, it is how you practice. But then whether your patient's level of muscle testing, that is your MMT, is as same as someone else, it would be definitely not. So in that case, you will have to always assess your patient, be very specific, and decide on what to start, when to start, and how much to start. So evidence definitely would help you, give you a way to do certain things, but it is your expertise which will help you that when to do it. One more example I would like to share. We all are aware we all be treating Bell's palsy patients. Now, when you have a case like Bell's palsy, generally what we all do is we have some infrared modality followed by an electrical stimulation for the patient, and exercise and PNF, certain other techniques. Now, let me just talk about electrical stimulation. My personal experience for electrical stimulation for a patient would always tell you that it is rather advisable to prevent truncal stimulation as well as to prevent surge ferretic stimulation to the patients, because it will be leading to synkinesis to the patient. So it is always advisable to have proper treatment to such type of patients too. So these are few examples which I would like to share you all, where you have to bridge your evidence with your clinical expertise. So next, uh, from my side, I would like to say it is practice-based evidence. It is the bridging the gap is a two-way street. While clinicians should look to a research, researchers should look to the practice-based evidence. And by documenting clinical outcomes systematically in a department, therapists can identify what works in real-world conditions, which differs from the controlled environment. So it should be a practice-based evidence along with your all three components of evidence-based practice, your clinical expertise, and your patient's need. Next, it is the art of science, and the gap is bridged between the practice and the, it is a process, it's not a product. EBP is a tool for empowerment. It's not a replacement of any clinical judgment, and I would also say it's the same vice versa. Even the clinical judgment is not the replacement of EBP. So here the goal is to follow a cookbook, not to follow a cookbook. It's not a recipe which is to be followed, but you have to integrate all the three pillars of research evidence, clinical expertise, and patient's value, and have a comprehensive method to follow the best physiotherapy practices. So this is how I would like to conclude my session. And before I conclude it, I would like to, I am very much grateful to our IAP, our respected Dr. Sanjeev Jha sir, Dr. Ruchi ma'am. I extend my sincere gratitude to respected state head Jaspreet ma'am, Alpa ma'am, Advita ma'am, for giving me this opportunity to be the speaker at this wonderful event. It has been a true honor and a privilege to share my insights and discuss with such an engaged audience. Special thanks to my entire organizing team and my panelist team for this warm hospitality. Special thanks to Grishma ma'am, our digital team, for arranging such a seamless experience. I hope that the insights I shared today will be valuable to all of you. Thank you again for this incredible opportunity. Wishing everyone a wonderful continuation of the event further. Thank you.
Thank you, ma'am. Thank you, Vaibhavi ma'am, for sharing such a beautiful insight on integrating the bridging the gap between clinical practice and evidence-based evidence available. So here I would like to thank all our speakers for such a wonderful elaboration. If we reflect on the insights shared by all of our speakers, one message that emerges out is that the evidence is going to inform us, the clinical practice is going to guide us, but the patient's needs and perspective is what will complete our clinical decision making. So it is not always choosing science over experience or choosing experience over science, but it is integrating both along with catering the individual patient's needs. So here I open the forum for any question and answer. I would request or invite the audience to put down any queries or questions in the chat box so we can address them. One question I would like to have from my side, that how do we actually integrate, say for example, we have a case of stroke or so. We know that there are a lot of evidences available out in the on the databases, but how do we actually implement that, and how do we decide that it is going to be helpful for my patient?
Ma'am, I would like to answer this.
Yes, ma'am.
Yes. Ma'am, as you said, if you have a patient and integration with what I talked about, we have n number of research background for stroke patients protocols. So first looking into your evidence available, at the same time, what is patient's need? One of the most important component which is always discussed is the shared decision, right? What is the age of the patient? What are the comorbidities? What is the expectation of the patient? And then having jot downing all this point at the same time, adding your clinical expertise, your previous experiences with your patients, and designing a protocol. And as I said, evaluation is something, or assessment and reassessment is something, is a cornerstone to any success. So you'll have to do it off and on to revise your protocols and have a early and a better outcome.
Sure, ma'am. Sure. Thank you. Thank you so much, ma'am. In case of any queries or so, the participants can put down the question in the chat box. The speakers can address it later on. So here we can conclude the symposium session. So at the end, I would like to thank all the speakers for such a wonderful and insightful thoughts. I would also like to thank our IAPWC Gujarat team, Jaspreet ma'am, Advita ma'am, Alpa ma'am, and along with that, Heta ma'am, for pushing us and encouraging us for this platform. Thank you everyone.
Thank you so much, everyone. It is an wonderful session, and it is very enlightening session as well. Um, I think it is being introduced very first time, but it is handled by panelists. It is at Outreach. It is wonderfully handled by all the panelists. Thank you so much, moderator, as well. Now we will be moving towards our valedictory session. So we'll be having first we'll be having one exciting opportunity that we will discuss, and then after this that will only take about 10 minutes, and then after we'll be having the most awaited movement, that is your prize distribution ceremony. So I just would like to ask to our digital media Alupi ma'am to share the screen. Yes, ma'am. Ma'am, full screen, please. Yes, ma'am. So the most uh, awaited things of September, I have an opportunity here to discuss with you. First, I just would like to ask you, everyone, have like any one of you have any time in your like journey of physiotherapy, have you ever attended any international conference? So how many of you have attended the international conference? Kushisha is saying no, yes. Any of you have attended any international conference? Maitri is also saying no. Then it is worth it to discuss. Yes. So, well, today I am here to introduce you to one such event, incredible event, which is being happened in September. That is World Physiotherapy Asia West Pacific Regional Conference 2016. That is right there in India. So I just would like to discuss that part. Next slide, please. Now tell me, who any of you are here as a member of IAP? IAP is an Indian Association of Physiotherapists. Of course, you all know our own professional, and that is a backbone. And I'm proudly saying that as an Indian Association of Physiotherapists member is and hosting this event. It is not just an organization hosting this. It's in what shapes our profession in India. So let's think practically about it. Next slide, please. So what do you need the most as a clinician? Or as in once you are graduated, what do you need the most? So first, you need safety, you need growth, you need recognition. Yes. So IAP addresses all of this. Insurance through the Suraksha scheme, that is a professional immunity insurance scheme that covers 10 lakhs rupees for a physiotherapist. A research grant to build the evidence-based practice, and it is emphasized on research and evidence generation. So this is how our profession grows, not just individually but together. Next slide, please. So in this journey as well, do you see yourself as a generalist or the specialist in the future? So IAP supports both. Next slide, please. So if I'll tell you the recent changes, that is specialty group in neurology, sports, and geriatric. And again, there is a clinical guidelines also is shared in the past conferences, that is geriatric, women's health, and the neurological condition specific, the post-stroke. So with specialty group in neurology, sports, and geriatric, and the strong clinical guidelines, it help us and even you more move from good to expert level. So behind every big movement, there is a strong leadership. So this conference is driven by dedicated professionals working to put India on the global physiotherapist map. Our own new national president, Dr. Sanjeev Jasar, and our treasurer and our IAP national head, Dr. Ruchi Vashna ma'am, and Dr. Nihal Shah ma'am, who is chairing this West Zone conference. Now imagine, what if you could connect with physiotherapists from across the world? That exactly what World Physiotherapy does. It unites us globally, setting standard for practice and education and research. Uh, Next slide, please. The AWP region includes around 32 countries. Just imagine the diversity of idea, techniques, and experiences in one place that is going to happen in to India. Next, please. We'll quickly finish it up, ma'am. Um, the region is guided by global experts, ensuring collaboration across the nations, which means learning beyond the textbooks, learning from real world and global practice. It is chaired by Dr. Marco and vice chair by our own Dr. Nihal Shah ma'am. Let me ask you something. Is the healthcare truly accessible to everyone today? That's exactly why this year's theme is Fitness for All, empowering communities, building inclusive health, a step towards making physiotherapists reach everyone. And the best part is we don't have to travel abroad. It's happening in right here at Yashobhumi Convention Center, New Delhi, a world-class venue right, in India. Next slide. The last conference was held in Bali and had participants from 31 countries. Now imagine the scale when India hosted. And I'm proudly saying that more than 7,000 participants already registered for this conference. These global events are not just in lectures. There are about networking, collaboration opportunities you didn't even know that which exist into it. We do have the interactive session in the form of scientific events, and here is is as in research there is an opportunity to present your paper. Even conference also offers speaker opportunity, abstract opportunity, workshops, brainstorming sessions, panel discussions, and many more. This is your chance not just to learn but to contribute. Next, please. And it's not all about serious and academics, because what's an events without some fun, right? So cultural programs and student forum make it vibrant and memorable. So do join us for the cultural as well. So here is a real question: why should you attend? Because this is where you grow professionally, but even you build the global connections. You see the future of physiotherapist. Ma'am, next, please. And here the best part is you get an international experience at the cost of national conference. And that's a very rare opportunity. If you are even slightly interested, don't wait. Follow the updates and stay informed and grab your chance for the registration. The link has been given to you. I'll end with one thought. Opportunity like this don't come often, especially at home. So the question is, will you just hear about it or be a part of it? So how many of you will join? One last question. Those who have not attended international conference, it's a good opportunity for all of you. Okay, thank you, ma'am. For the more information, you can connect with us. Now I'd like to invite our next host, Dr. Harsha ma'am. Harsha ma'am, floor is yours.
Yes, ma'am. Thank you, ma'am. Respected guests, dear participants and colleagues, as we are now headed at the end of our successful event, this is Dr. Harsha Yevle, and it's my pleasure to begin the valedictory function. I had like to extend a warm welcome to our esteemed guest, Dr. Nehal Shah, who is the Joint Secretary at IAP and Principal at SB College of Physiotherapy, and Dr. Neeta Vyas, former Principal and Senior Advisor at AIMS College of Physiotherapy. I would like to begin the valedictory function with Dr. Nehal Shah. She is a Vice Chair at Asia's West Pacific Region, World Physiotherapy, and Principal at SBP College of Physiotherapy, Ahmedabad. With 30 years of academic and clinical experience, specialized in orthopedic physiotherapy and electrophysiology. She also serves as Joint Secretary at West Zone and National Head Research Committee of the IAP. Dr. Nehal Shah has delivered over 100 plus lectures worldwide and presented researchers at World Physiotherapy Congresses. She has contributed to the research project of Australia-India Trauma Systems Collaboration to reduce the injury burden and delivered a lecture as a panelist speaker for system collaboration to reduce injury burden. And she has delivered a lecture as a panelist speaker for the WHO on a topic fall prevention in the elderly. Dr. Nehal ma'am has also contributed as a speaker at World Physiotherapy Congress. She, as an international faculty member and as a reviewer, she actively serves on academic boards, advancing physiotherapy education and practice globally. She has received various awards for her dedicated work towards our field. Now, let's welcome Dr. Nehal Shah, ma'am, to share her valuable insights with us. Over to you, ma'am. Thank you.
Thank you very much and good morning, everyone. I hope you had a cherishing yesterday with a day full of learning and understanding. It's indeed my privilege to be here and to address you people, not just as a guest of honor, but in my capacity as a Vice Chair, Asia West Pacific World Physiotherapy, Joint Secretary, IAP, and Principal, SBB College of Physiotherapy. As I am a proud physiotherapist, I would always say I'm a proud physiotherapist and a proud member of ever growing physiotherapy fraternity, that is IAP. So with this, I extend my heartfelt congratulations to the entire IAP Women's Cell Gujarat team for arranging this wonderful case presentation or case series presentation and panel discussions, very enriching days. You know, case presentations, they teach you a lot. I mean, routinely when you get a patient, you treat the patient and the patient goes back. The next day you ask, how are you? And the patient says, I'm fine. But when we talk about this kind of case series presentation or case study presentation, it actually teaches you documentation. It actually teaches you how you should approach the patient, how you should strategically plan the management, and how you should document the results. And so this is really the need of an hour. Along with enriching panel discussions, I'm sure IAP Women's Cell Gujarat has made this event really memorable for everybody. Not many would know, but I have begun my career as the district coordinator of Ahmedabad for IAP Women's Cell, from where I became the state coordinator IAP Women's Cell. So I'm born from IAP Women's Cell. And so, I'm really always very happy when any Women's Cell event invites me, because then I feel I've come back home. So today's case study presentations, they were not just academic exercises, they were the reflection of clinical maturity, reasoning, and compassion in practice. As an academician, I am really encouraged to see young physiotherapists moving ahead and presenting the cases. And I would just like to say to everybody, all the young budding physios here, your degree gives you a title, but your clinical reasoning skill gives you identity. So whether you receive an award today or not, you have already won because you have had the courage to present your case here. The best clinician is not the one who knows the most, but the one who thinks the best. And today, that thinking was clearly visible today and yesterday, of course. I also sincerely appreciate IAP Women's Cell for creating such an empowering platform. The brain behind this is our own national head, IAP Women's Cell, Dr. Ruchi Vashne, and our national president, Dr. Sanjeev Jhasar, whose visionary effort has taken IAP Women's Cell to this level today. And these are not just events, they are investments, according to me, which builds up future leaders in physiotherapy. Always remember one thing, patients do not come to us for exercises. They come to us for outcomes, confidence, and hope. And so let us continue this quest of learning ahead, keep on doing good things. And I'm sure Jaspreet Madam, leading IAP Women's Cell Gujarat, is all set with her vision, with her ideas, and with all the support and all the dedication to take this ahead. And maybe next time we can have a bigger event, bigger than this, and make IAP Women's Cell Gujarat one of the best states in entire year. And let this not be just the end of an event, but beginning of a better clinician, stronger thinkers, and a more powerful physiotherapy profession. Once again, I congratulate everybody, all the entire Women's Cell team, Alpa, Heta, Shipra, Grishma, and many whom I have must have forgotten the names. But congratulations to everyone. And thank you once again for inviting me. Thank you so much.
Thank you, Nehal ma'am. I'd like to invite our second valedictory function speaker, Dr. Neeta Vyas ma'am. She is a senior advisor at AIMS College of Physiotherapy and worked as an ex-principal of IKDRC College of Physiotherapy and SBB College of Physiotherapy. She is a member of board of studies at various universities with 45 plus of experience in academic and clinical practice. She has a dedicated work in our physiotherapy field, received fellowship and lifetime achievement IAP award. She has been author and co-author in various physiotherapy books. She is having with over 50 plus publications at various national and international journals. She has also contributed in delivering lectures at various national and international platforms. She has also been for various international and national platforms. Now I would like to welcome Dr. Neeta ma'am for her valedictory speech. Over to you, ma'am.
Hello, good afternoon, everyone. It's, I think, 12 noon. And it was real good time for me yesterday and today, listening to all participants, is this conference. I think every year, Jaspreet Madam has tried to organize such a conference where everyone easily participates virtually, present virtually, and that is what, because of this theme, I think this was a success. I can say real success, because hearing so many good participants, this is not a job, I can say. હું એમ કહી શકીશ કે આપણે 2 દિવસથી જે બ્રેન સ્ટોર્મિંગ ટાઈપના બધા ચાલી રહ્યા છે, એક પછી એક પેનલિસ્ટ છે, બધા પ્રેઝન્ટેશન છે, એ બધું ઘણું બધું આપણને શીખવી ગયું. મેં ગઈકાલે સાંજે એક પેનલમાં એ જ વાત કરી કે હું પણ I am also refreshing myself by attending this conference. So first of all, thanks to Sanjeev Jha sir and Ruchi madam, and especially Ruchi madam, who started this our woman cell uh, in IIT, all women entrepreneurs to just grow in this field. So very much thankful to her. And I would like to say that if I can say that today this theme, bridging knowledge to care in digital area of physiotherapy, I would like to tell you one story in that on that theme. There was young doctor, young physiotherapist who was running her clinic. One morning she was just looking at her list, and then she felt that there was one patient, Mr. Shah, who was recovering from her knee replacement. He lived alone and struggled with technology and often missed his follow-up sessions. So it was just few years ago. If this would have meant slow recovery and frequent complications, but this was digital era of physiotherapy, we can say, where knowledge travels faster than distance. So the physiotherapist scheduled a virtual session with Mr. Shah. He appeared on the screen. He looked on the screen, but he was not sure and confident. But he was hopeful that something would be much better. So the physiotherapist told that Mr. Shah, we can say Dr. Meera, I just give a name, Meera, that she told that, don't worry, sir, we do this together and you will really come out of this. So on that, she started demonstrating exercise using digital model on her screen. Mr. Shah followed carefully, adjusting his posture as she guided. She recorded short exercise programs and sent him on the phone along with reminders and progress tracking. Over next few weeks, something remarkable happened. Mr. Shah became more confident. He started walking without support, reported less pain, and even began reminding Dr. Meera about the next session. So when prior Dr. Meera was asking him to remain present, but now he started that please send me the next videos. So one day during the session, he said, earlier I thought physiotherapy meant coming to clinic only. Now I feel clinic has come to my home, to me personally. So Dr. Meera smiled and she realized that technology has not replaced the care. It has strengthened it. Through digital tools, clinical knowledge transform is accessible, personalized care is done, distance has faded, engagement improved, and recovery became a shared journey. So in this digital era of physiotherapy, bridging knowledge to care was no longer just an idea, it was a reality, one patient at a time. So see how we can help patients, we can help students. We have seen during COVID, we were taking lectures during those on digital platforms, and that is how the knowledge has carried in digital era of this physiotherapy profession. And discussion of 2 days, I can only see that if students have attended this conference, they have done more was not also they would have not done prior if they were attending classes in the college. So this was real good college, and I hope next time just be more something new out of this. And before that, please attend AWP conference is really important. It has come after 16, 17 years in India. So it is just a few hours away from Gujarat. We can attend, enjoy, we can make new friends, fellowship, and that would help us to interact and know new, learn something new which we don't know sometimes. So my request to everyone, please, if you have not registered, register early so you get a place and you can enjoy. Thank you very much and heartiest congratulations for this successful conference. And now I hand over to Harsha Madam.
Thank you, ma'am. And now the moment we all have been waiting for. Let's congratulate our all the participants who had put their knowledge in our competition and the conference. But I would like to, before I announce the winners, I would say a big shout out to all the participants. Your presentation were phenomenal, and you all did an amazing job. It was a tough to pick up the top winners in the conference and the competition. But yes, we have our winners. I would like to welcome Dr. Nita ma'am to announce the winners. But before announcing the winners, I would like to tell you the category of the pricing. The exciting, we have launched exciting prizes.
Harsha ma'am, are you there? Harsha ma'am?
Yes.
Ma'am, we have Jaspreet ma'am here with us. So
Sorry, ma'am, that was a network issue.
that's okay.
So before we go towards the names of the winners, before we go towards the name announcement of the winners, I would like to tell the exciting prizes our winners will be getting from the today's conference. So in each category, now there are total 2 and 3 winners. In Neuropedia, we are having first and second rank. First rank will be getting the prize and the cash amount of rupees 1,000, and second rank will be getting the cash prize of rupees 700. In the women's health, cardio, and CPR, we are having first and second ranks. First rank same 1,000, second rank same 700 rupees. And in the ortho 1 and ortho 2 group, yes, ma'am. In the ortho 1 and 2 groups, there are total 3 rankers. First, second, and third rankers will be getting the cash prize of 1,000, 700, and 500 rupees respectively. So I would like to welcome Dr. Nita ma'am to announce the names of the winners of today's conference. Nita ma'am, handing over the platform to you.
Congratulations to all the winners first. And before I start this, I just forgot to say something. I just wanted to say that the vice chair of AWP is our own Dr. Nehal Madam. So we don't have to tell you that please come. You have to just see her that from Gujarat, Narendra Modi is there. So Nehal Madam is there. No. So we can attend this AWP conference without fail. And it is, I can say it is mandatory from Gujarat. We should show Gujarat's strength there. So my request to everyone. Okay, now I declare the winner in ortho group.
Heta ma'am.
Dr. Maitri Nitin Kumar Patel, postgraduate Ashok and Rita Patel Institute of Physiotherapy. Second rate Vaishnavi Gore, MGM School of Physiotherapy. And third, Dr. Vedanti Mundada, postgraduate from Chhatrapati Physiotherapy College, Sambhajinagar.
I'm next.
The third rank is between two students. One is
Ma'am, I think there's a network issue is there.
so the third prize is divided between two. Ortho Group 2, Dr. Shraddha Jawar. She is a postgraduate student from Parul Institute of Physiotherapy, first rank. And it is secondly divided into two. Rushti Mahesh Kumar Dave, postgraduate student from Ashok and Rita Patel Institute of Physiotherapy. So both of are getting first rank in Ortho Group 2. Second rank, Dr. Sukesh Yahul. She is from Yendupa Physiotherapy College, I think, Mangalore. And Rucha Patil from MGM School of Physiotherapy, Mumbai, Navi Mumbai. Now we go to cardio rehab group category for Sushil Christian from SBB College of Physiotherapy. In second, Institute of Physiotherapy. Now, in Neuropedia, first rank goes to Dr. Govindu Nayak, SVIMS Institute of Medical Sciences. And second rank goes to Vishwa Parag Bhavsar, Ahmedabad Institute of Medical Science. Congratulations to all the winners. Thank you.
Kindly note that all the winners will get in cash prizes. The first rank winner will get in 1,000 rupees. Second rank will get in 700 rupees, and third rank will get in 500 rupees. You will be receiving soon. Congratulations to all the winners. Now I would like to invite our own Gujarat State Coordinator, Dr. Jaspreet ma'am.
Thank you, Heta. I'm sorry I'm traveling at this moment, but I would like to congratulate each and every one of my team. You all did a great job in such a short notice. Congratulations to all the winners. And thank you, Neeta ma'am, Nehal ma'am, for your presence and blessing everyone today. I would just say that this whole success goes only and only to my team. not to me, because they all have worked very hard behind this and the success is theirs. So well done, and we will keep bringing more such events together further. Thank you so much for everything. Thank you, team. You did a great job.
Thank you, ma'am, for this inspiring words. Now I'd like to invite our state sub-coordinator, Dr. Alpa Purohit, ma'am, for the further sessions.
Thank you, Heta. And once again, congratulations to all the winners and respected dignitaries, esteemed guests, panelists, and dear participants. A very good morning. Sorry, not good morning. It is a good afternoon to everyone. So special thanks to Dr. Jasprit Kaur ma'am, under whose guidance he is a state head IAPWC, principal of KD Institute, Ahmedabad. We have successfully organized this wonderful conference. Her constant support, leadership have truly inspired us. Thank you so much, ma'am, for guiding us on each and every step. And next, I would like to extend my heartfelt gratitude to all the organizers, Jasprit ma'am, Arvind ma'am, myself, who have beautifully organized this conference with a great dedication and teamwork. So actually, this idea came up during the discussion with the Advaita ma'am. You know, the AWP conference is coming, and we thought of organizing a state level conference with a something new and innovative idea. And the number of entries that we have received in such short notice, so it truly reflects the enthusiasm and success of this initiative. The organization has been truly wonderful. My special thanks to us for these 2 days, Aisha madam, Harsha ma'am, Vaibhavi ma'am, Komal ma'am, Heta ma'am. And one more thanks to our special panelist speaker for panel 1, Nehal ma'am, Bhavna ma'am, Dhara ma'am, Suvarna ma'am, Meeta Saxena ma'am, Megha ma'am. And for panel 2, Dr. Neville Deepak sir, Lognathan sir, Dr. Dharman sir, Dr. Janvi Vaidya, Dr. Pragna ma'am. And that panel was very well coordinated and moderated by Dr. Joel ma'am. And panel 3, which was in panel 3, the speakers were Advaita ma'am, Gopi ma'am, Komal ma'am, Heta ma'am, Krishna ma'am, and which was moderated by the Nupur ma'am. So thank you all for sharing your valuable knowledge and giving a new insight and approaches to the students and academicians. Now I would like to say a special thanks to entire scientific committee members, Advaita ma'am, Joel ma'am, Krishna ma'am, Komal ma'am, Alopi ma'am, Nupur ma'am, Khyati ma'am, for the dedicated academic contribution behind this scene. A big thank you all our coordinators, those who have coordinated the session very nicely. Krishna ma'am, Grishma ma'am, Disha ma'am, Priya ma'am, Harsha ma'am, Shweta ma'am, Pallavi ma'am, for nicely coordinated this session. And a special thanks to our judges who have spared their precious time for this session. At last, our participant, your active involvement made this event a grand success. And heartfelt to team, Dr. Heta ma'am, Dr. Alopi ma'am, Dr. Harsha ma'am, for their continuous support and smooth execution of this event. And I would like to express my special appreciation to our inaugural guest, Dr. Ruchi Vashne ma'am, Dr. Yagna ma'am, and our valedictory guest, Dr. Nehal Shah ma'am and Neeta ma'am, for sparing your valuable time for us. And gratitude to our mentors for their continuous support. So we also extend our gratitude to those who may not be present here, but whose guidance and blessings are always with us. Dr. Sanjeev Jha sir, IUP President, Dr. Ruchi Vashne ma'am, National Head, Dr. Pooja Kamble, Zonal Head, IAPWC, Dr. Jasprit ma'am, Dr. Neeta ma'am, Bhavna ma'am, Megha ma'am, Nehal ma'am, Anjali ma'am, Nilima ma'am also. So thank you so much for your blessings on us. And finally, I would like to express my deepest gratitude to the Almighty for making this event very successful. Thank you everyone for your presence, support, contribution in making this conference memorable one. Thank you once again. Thank you all.
Thank you so much, ma'am. Now we are inviting our participants to share their feedbacks. If anyone wants to share the feedback. Still, the exciting news is in on the way. From our team, anybody would like to share the experiences? And once again, congratulations is shared by our state head, Dr. Jaspreet ma'am, to all the winners. Anybody would like to share in feedback about the conference? Surbi has shared that it was indeed the most interactive session, even it was online. Thank you. Thank you so much, Surbi. If anyone would like to share, then we'll allow you to talk and as in panelist. Meanwhile, it is a great opportunity to share on behalf of state Gujarat state. We are announcing very soon from 18th of May 2026 and in collaboration with IAP Research Committee and IAP Gujarat State, organizing 10 days online research series specifically for systematic review and meta-analysis. It will be for undergraduate students, it will be for postgraduate students, PhD scholars and faculties and the professionals. And it will be running in afternoon from 1 to 3. And all the participants will get a certificate. So you all are welcome for this event, and we'll be sharing this information about speakers, moderators, and everything in upcoming week. We'll share it soon. And this is also a vision of our IAP research committee. So I hope you all will join this online research series. Now we are up to the end of this session. Thank you so much, all of you, for joining these 2 days. Thank you, everyone, and have a good day.